Good morning, and welcome to the 2022 Delaware Cancer Consortium Retreat. I'm Katie Connolly, Chair of the Delaware Cancer Consortium. On behalf of the Delaware Cancer Consortium, I thank you all for joining us today. I thank you all for joining us in the commitment to decrease the cancer incidence rate in our state and to help ensure that Delawareans who are diagnosed with cancer have full and equal access to the care that will help them survive cancer. I know many of you had hoped we'd be able to gather in person this year, especially me, but I encourage you to embrace this virtual format. It works, and it's a great format for learning and connecting. And plus, I assure you, the screens between us cannot stop the power of our shared life experiences. By this, I mean our shared pride as Delawareans, and I'm a lifelong Delawarean. I also mean our shared journeys with cancer. We all, myself included, have friends, family members, extended family members, colleagues, friends of friends who have heard the words, "I'm sorry, it's cancer." Maybe these words have been spoken directly to us too. For some of these people, we have mourned a great loss. For others, we have celebrated their survival. For all of them, we made sure to support them physically and emotionally, with practical help, with knowledge, and sometimes just by offering a hand to hold. I truly believe that these experiences, as painful as they may have been for us, have brought us together here today. They inspired us to do more, to turn the tide against cancer in Delaware by uniting in the mission of the Delaware Cancer Consortium. As we work through today's agenda of learning, sharing, and building the resources we need to carry out our work in the upcoming year, I ask you all to remember this. Remember the personal inspirations that have made Delaware's cancer mission a part of your life. Remember the encounters you've had with community members in need and the ways you helped them make the connections that made the difference in their journeys. Each of these experiences helps create your own legacy in Delaware's fight against cancer. That's one of the meanings behind our 2022 retreat theme, guided by our legacy, prioritizing healthy living. The other is more literal. A legacy we will honor later this morning by paying tribute to the life and impact of former Governor Ruth Ann Minner. As many of you know, the Delaware Cancer Consortium was originally formed in 2001 as the Delaware Advisory Council on Cancer Incidence and Mortality. Created by Senate Resolution 2, which was signed by Governor Minner, the Delaware Cancer Consortium, and I will argue every step forward in every major victory, was the direct result of Governor Minner's advocacy, tenacity, and uncompromising commitment to prioritizing healthy living for every Delawarean, especially those in underserved populations. Through the work of Governor Minner and through the work of all of you who have been part of our mission since 2001, the Delaware Cancer Consortium has moved the needle in terms of the number of people who get screened for cancer, stop using tobacco, and or stop exposing others to secondhand smoke. And indeed, this has paid off in lives saved. Delaware's data, compared to the national averages, demonstrates our accomplishments. Still, as we are all well aware, we still have unfinished business to tackle in this mission, and doing that starts today here with this retreat. It is an honor to introduce our first speakers, three women who have their finger on every pulse that has to do with the health of Delaware and Delawareans. When we talk about prioritizing healthy living, these three leaders take that concept off the charts. Personally, professionally, day in and day out, they are making the top-tier decisions that need to be made for the well-being of the state. But you will also find them in the trenches, sleeves rolled up, making connections and making sure people are aware, educated, connected, and empowered. Especially over these past 2 years, you can imagine how busy they've been. Please join me in welcoming Secretary Molly McGarrick, Delaware Department of Health and Social Services, Cassandra Coates Johnson, Associate Deputy Director, Division of Public Health, who is filling in for Dr. Carol Rattay, who could not be with us today, and Lieutenant Governor Bethany Hall Long. Welcome.
Good morning. Thank you so much, Katie. It's always so wonderful to see you. And I'm just so excited to be with everyone this morning. And wow, 2 decades. It went by in a blink. But, to take us back as you did, 2 decades ago, Delaware had one of the highest cancer mortality rates in the country. And the state's incidence and mortality rates for all site cancers needed attention and needed a strategic plan and leadership because of the burden that they were causing Delaware families, which is why we had then Governor Ruth Ann Minner step up to be that leader. And she declared cancer one of her top 3 health priorities. And as you referenced, in March of 2001, she took that first step, signing the resolution to create the Delaware Advisory Council on Cancer Incidence, which was led by our friend Bill Bowser as the chair. And it was just a year later that advisory council issued recommendations, and the leading one was to make the advisory council permanent. And as again you referenced, that decision really set the wheels in motion to create the Delaware Cancer Consortium and all of the amazing progress that has flown from there. And many of you remember who Governor Minner's lieutenant governor was, now our governor, John Carney. And he was entrusted as the chair of the committee, the consortium's disparities committee. And under his leadership, they began to look at ways to improve outcomes, data sharing, and importantly, to again reduce disparities. And so Governor Minner not only created the Cancer Consortium, but the framework that she set in motion really strengthened health partnerships and resulted in important new programs. Specifically, since 2002, the Screening for Life program and the Division of Public Health has provided more than 30,000 people with breast, colorectal, cervical, prostate, and lung cancer screenings. And that program has detected almost 3,400 abnormal breast and cervical cancer results, connecting people to early interventions, which we know save lives. And also in 2002, just earth-shattering, groundbreaking, steel spine leadership, Governor Minner signed into law the Clean Indoor Air Act, which made Delaware only the 2nd state after California to ban all indoor smoking. And we will never know how many lives that ban and Governor Minner's leadership saved. But we do know that Delaware's smoking rates have been on a steady decline since that bill was signed into law. And the Delaware smoking rate has dropped to about 15% in 2020, and the youth rate is down to 4% as of 2018. Not stopping there, in 2004, Governor Minner launched the Delaware Cancer Treatment Program, and this program continues to be a leader and a standard bearer across the country, providing 24 months of medical coverage for uninsured Delawareans, including undocumented people who earn up to 650% of the federal poverty line. And since then, more than 2,300 people have received surgery, chemotherapy, radiation, and stem cell treatments through this program, again, saving even more lives. And in 2005, a huge step forward for equity, nurse navigators were deployed to help steer Delawareans through the complex maze of cancer screenings, tests, and appointments. Initially, there were 5 contracted nurses that were based in our hospital, but today there are 12 patient navigators across the state, including those who speak Spanish and Haitian Creole. And they meet patients where they are, and they build trust at every step. In a March article in NPR, which I know many of us have been talking about and saw, and it talked about Delaware's success and really credited it to the Nurse Navigator program. And to quote one nurse navigator, Mary Jo Vasquez, who was interviewed, she talked about the critical role of the relationship building. And she said, they, as in the patients, have to learn that we are here for them. We want to help them, and we are not going to abandon them. And again, that commitment has really paid off, and we have started to see it in our data over the last 20 years. Looking at 2 5-year periods from 2003 to 2007 to the period of 2013 to 2017, Delaware's all-site cancer mortality rates decreased by 26% among non-Hispanic African-American males and 15% among non-Hispanic Caucasian males. And in the same period, Delaware's all-site cancer incidence rates decreased by 12% among non-Hispanic Caucasian males, 22% among non-Hispanic African-American males, 12% among Hispanic males, and 9% among Hispanic females. Yet despite all of that progress, as you all know and work with every day, we still have more to do. Delaware still ranks 15th highest in the US for all-site cancer mortality for the periods of 2012 to 2016 and 2013 to 2017. And Delaware was also second highest in the nation for all-site cancer incidents from 2013 to 2017. And we know many factors play a role in these numbers. Obesity prevalence among Delawareans has more than doubled between 1990 and 2018, going from 47% to 68%, or more than 2/3 of Delaware adults. And sadly, that trend is cascading down to our children. About 15% of Delaware children ages 10 to 17 are obese. And a 2016 NPR story offered at least one compelling reason for this increase. To quote the article, American children see on average 3 to 5 ads for fast food per day. And about 50% of all ads directed at children are about food. If we can take steps to change our country's obesity and overweight rates, which we know are propelled again by fast food, portion sizes, and limited physical activity, we may reduce not only diabetes, hypertension, and cardiovascular disease, but also certain cancers. And again, you all know through your work that there are also systemic inequities that drive obesity, including food deserts, which are places without access to healthy food and beverages. We also know that some of our Delaware neighbors live in places without playgrounds and access to other physical activity opportunities, or they live in high crime areas where they don't feel safe enough to go outdoors and exercise. And it's also hard to put nutritious food on the table when nearly all of your budget is going to rent and childcare. And throughout the pandemic, we have seen these broader equity issues also result in higher cases of COVID. It's really hard to stay safe from an infectious disease when you're a frontline worker every day, or you live in a multi-generational household. And so while there is always more work to do and new issues to solve, I want to end on a positive note, which is where I started. And that's congratulating the members of the Cancer Consortium, past and present. And I will say there are so many people who have been on the consortium since the inception who are still involved today, which again is a testament to Delaware and how strong we are when we work together. So again, I congratulate you and recognize all the decisions you have made, the programs you have launched and supported, and the countless lives that you have changed and saved over the last 20 years. And year after year, it is abundantly clear to everyone in Delaware, you all are doing work that matters. And now it is my pleasure to introduce someone whose work also supports the health of all Delawareans. Cassandra Coach Johnson is currently the Associate Deputy Director for the Division of Public Health under DHSS, and she provides support and oversight to almost 1,000 public health staff who work daily to promote and protect the health of Delawareans. She oversees many sections, including health promotion and disease prevention, maternal and child health, and rural health. Including her work at DPH, Cassandra has over 20 years of experience in public health, including community-based work, and she is considered a subject matter expert on topics related to health equity and addressing social determinants of health, not just in Delaware, but across the country. She is one of the co-authors of the Delaware Health Equity Guide for Public Health Practitioners and Partners. And again, she has worked for national and international organizations such as Family Health International, Administration for Children and Families, Mathematica, Nemours, Centers for Urban Families, ICF International, the Annie E. Casey Foundation, the White House Office of Faith-Based and Neighborhood Partnerships, Brookings Institute, and Columbia University, among others. I don't know how she does it all. She's also an amazing mom to her incredible daughter. And she just does wonderful work every day. And I am so proud to have been able to get to know her working at DHSS. And I'm so proud to call her a colleague and see the incredible work she does on behalf of Delawareans, and frankly, setting example for the rest of the country. So with that, I will turn it over to Cassandra. Thank you all so much. And I hope you have a wonderful retreat this morning.
Thank you so much, Secretary McGarrick. And I just want to take a quick moment before I jump into my presentation to really thank you for your continued leadership and support for the Division of Public Health and also for the work of the Delaware Cancer Consortium. You are an advocate, and your leadership allows us to do the work that you described so eloquently in your presentation every day. Thank you all for being with us today. I am standing in for my amazing leader and boss, Dr. Kara Rattay, who sends her regrets. She's not feeling well today, and even superheroes need a day off, right? So I am happy to step in for her to be able to be a part of this awesome retreat and celebration. I'm going to take a few minutes to actually ground us in some data that we can hopefully carry with us through the day. And if someone can bring my slides up, I think we can start with the presentation. So I don't actually see the slides coming up on the screen yet. I'm not sure if other folks can see the slides, but I can. Here we go. Thank you. So I'm just going to spend a few minutes just to ground us all in some data. Next slide, please. So Secretary McGarrick kind of laid out a lot of where we've been, right, and where we need to go, right? So we've made a lot of progress as it relates to cancer over the last 20 years, but she also was able to highlight some areas that we really need to continue to lean into. So I'm just going to add some additional context around that. So heart disease, for example, and stroke cost our healthcare system, according to the Center for Disease Control, $216 billion per year, and causes $147 billion in lost productivity on the job. Cancer is our nation's second leading cause of death, with almost 600,000 dying from it every year, and more than 1.7 million people being diagnosed with cancer. The cost of cancer continues to rise and is expected to reach almost $240 billion by the year 2030. In 2017, the total estimated cost of diagnosed diabetes was $327 billion in medical costs and lost productivity. And in 2020, the estimated cost of caring for and treating people with Alzheimer's disease was $305 billion. By the year 2050, these costs are projected to be more than $1 trillion. Next slide, please. So with statistics like these, it really tells us, right, that we have a lot of work to continue to do. We use data and we use health equity centered data to try to help us really dig deep and drive into where we need to be really focusing our investments. So when we talk about cancer screenings, our data is telling us that we follow the national trend with a dip in cancer screenings in 2020. We know that COVID-19, right, wreaked havoc on the ability for people to keep up with their regular screening schedules. According to both the Behavioral Risk Factor Survey and internal data from our Screening for Life program, there were slight decreases in screenings for breast, cervical, and prostate cancer. But the good news is that the numbers have picked up in recent months. Our Behavioral Risk Factor Survey data is collected through a national random survey, and our Screening for Life program targets Delawareans who are uninsured or underinsured to help them pay for cancer screenings. Some modeling and studies through the National Cancer Institute have estimated that delayed screening and treatment for breast and colorectal cancer may result in almost 10,000 preventable deaths in the United States. Delays in cancer screening will require more cancer treatment costs for the influx of late-stage cancer cases. With the efforts of the Delaware Cancer Consortium, our hospital partners, our primary care partners, and all those who are doing this work every day, we are trying to make sure that folks have the tools, knowledge, and access to complete their timely cancer screenings. Over the last several months, the Division of Public Health, the Delaware Cancer Consortium, in partnership with hospital partners, have launched public information campaigns that urge Delawareans to schedule their screening appointments. And these public information campaigns will continue through the remainder of this year. Next slide, please. So when we talk about our data and actually look at it from a health equity lens, we really try to disaggregate our data by both race and ethnicity. And as it relates to our prostate cancer mortality, when we look at that disaggregated by race, from the period of 2013 to 2017, our male population continues to have higher rates of both cancer incidence and mortality compared to our female population in Delaware. Lung cancer is the most commonly diagnosed cancer in Delaware for males and females combined. Breast cancer is the most common cancer in females, and prostate cancer is the most common cancer diagnosed in males. In the period 2013 to 2017, Delaware had a statistically significant lower prostate cancer mortality compared to the US. So that's the good news. So our Delaware rate was 16.9 per 100,000 persons, and the US national average was 19.1 per 100,000 persons. However, when we stratify that same data by race, our non-Hispanic African American males had a significantly higher prostate cancer mortality rate compared to our non-Hispanic Caucasian male population. It was 34.1 per 100,000 persons for our non-Hispanic African American males, in comparison to 14.2 per 100,000 persons for our non-Hispanic Caucasian males. So although prostate mortality has decreased overall since from 2003 to 2007, the disparity gap among Caucasian and African Americans has existed and persisted over time. Next slide, please. Now let's talk about our breast cancer mortality data by race. So for the 2013 to 2017 period, the difference in female breast cancer mortality rate between our white population and African American population was not statistically significant. Although the difference among races was not statistically significant in Delaware, we know that according to recent data by the CDC, from our 2014 to 2018 timeframe, African American women in the United States overall had a significantly higher female breast cancer mortality rate than our white population in the US. For our African American women, the rate was 27.4 per 100,000 persons, and in our Caucasian women, it was 19.6 per 100,000 persons. Our breast cancer mortality rates for our Hispanic female population could not be calculated, unfortunately, due to smaller numbers of deaths. And I just want to mention that this data in particular is really personal to me and part of why I stay so engaged in this work, because my aunt is actually one of those statistics. She's one of those numbers. She died from triple negative breast cancer in 2017. So we all have a lot of collective work to do in that area. Next slide, please. Now let's talk a little bit about our lung cancer data, disaggregated by sex and race. So in 2013 to 2017 timeframe, Delaware had a significantly higher lung cancer mortality rate compared to the US. Our Delaware rate is 46.2 per 100,000 persons, and the US national average is 40.2 per 100,000 persons. When you stratify that by sex, our male population had a statistically significant higher lung cancer mortality rate compared to our females. Our male population were 56.5 per 100,000 persons in comparison to our females at 38.3 per 100,000 persons. While not displayed on the graph above, males also had a significantly higher lung cancer incidence rate compared to our female population. Although lung cancer mortality trends overall are trending downward, which is the good news, males have consistently been more affected than our female population. The difference in lung cancer mortality rates between our non-Hispanic Caucasian and non-Hispanic African American populations were not statistically significant. And also mortality rates for lung cancer in our Hispanic population could not be calculated due to the small number of deaths. Next slide, please. So with all of this data, how are we moving forward? What is some of the work that we're, involved in? I'm just going to highlight a few examples because the work is just too vast to mention in the short amount of time I have with you this morning. So improving health across the state of Delaware continues to be a top priority of the Delaware Cancer Consortium and with public health. We aim to really lean in, as you see on the previous slides, to disaggregate our data to understand where we need to be focusing investments, right, so that we can reduce some of these disparities. We aim to reach our most affected populations, specifically people of color, our LGBTQ populations who are also disproportionately impacted, and others who face higher rates of diabetes, obesity, heart disease, stroke, and cancer. Some of the tactics that we use are related to marketing, right? And so on this slide, it talks about the array of marketing tactics that we use, from toolkits for work sites to toolkits for school settings, to mass media campaigns, small media campaigns, all with the goal to both raise awareness to some of the information I shared on the previous slides, but also to encourage and urge people in these priority populations to get screenings, keep up with their screenings, and to seek the care that is available, and to make sure that they are aware of all the wonderful programs that Delaware has in place to support them. A lot of it due to the work of Governor Minner. Next slide, please. So it's really important to focus in on place. And that's one of the priority equity strategies that the Delaware Division of Public Health has been doing over the last decade or so in partnership with the Delaware Cancer Consortium. We continue to use a place-based approach to address what we call the vital conditions of health, or the social determinants of health, which are basically the places where we live, work, play, and pray. Right. And so these inequities on the previous slides that I discussed are persistent. These inequities are structural, and these inequities will take all of our collective effort to dismantle. And through the work of the Delaware Cancer Consortium and the work of the Division of Public Health, we continue to work in this area through partnerships such as Healthy Communities Delaware. Healthy Communities Delaware is another Division of Public Health partnering with other entities to support community-based organizations in focusing on place-based strategies to address the vital conditions of health, to also align investments for maximum impact in those communities. So the Healthy Communities Delaware is a partnership between the Division of Public Health, the Delaware Community Foundation, and University of Delaware Partnership for Healthy Communities. And through these three entities, they're really working to support and work alongside community-based organizations who are in the trenches every day doing this work, and help to support them with longer term funding and investments that really help them to lean in to addressing some of the inequities that were shared on the previous slides. Next slide, please. Another strategy that it's important to mention that the Delaware Division of Public Health has really been focusing on, say, over the last 5 years, is the build out of access to reliable public health data. And that is the launching of our My Healthy Community data portal. The portal was launched in 2019, but the work to develop the portal started long before that. The Division of Public Health has been working since 2014 to bring My Healthy Community data portal to life. This is an online platform that supports place-based health. This site provides access to reliable, publicly available data from many sources that are validated. The site is HIPAA compliant, which is huge. And so all the data indicators that are available on My Healthy Community portal, we hope that every Delawarean and every sector are able to use this to help them have reliable, equity-centered data to build strategies to address social determinants of health, and strategies to help them more effectively target their investments and the way in which they do their work to reduce inequities. Next slide, please. Another strategy that the Delaware Cancer Consortium, in partnership with the Division of Public Health, is also trying to move towards is making sure that we are providing access to what people need when they need it, right? And so there are a number of initiatives that are underway now where we are really leaning in to work across sectors, doubling down on equity approaches as we move into the future. One of the things that COVID-19 highlighted for us, but these are things we already knew, but COVID-19 put it front and center, is that it takes all of us, no matter what sector we work in, whether it be transportation, whether it be those working in the domestic violence space, whether it be those working in our maternal and child health space, whether it's those in our healthcare space, and the list goes on and on. It will take all of us, right, to work together to help reduce these inequities, to ensure that people have access to what they need when they need it. And nothing kind of brought that to light in a more glaring way than what we've been dealing with over the last 2 years with the pandemic. Next slide. So Delaware Cancer Consortium and Division of Public Health have really put a stake in the ground to really center equity in everything that we do. Dr. Atay is hugely passionate about this equity-centered approach, as am I, and we are really looking to ensure that as we move forward into the future beyond COVID-19, that equity is at the center of all of our work. Next slide. One of those really equity-focused strategies related to tobacco that I just want to highlight, for example, is really leaning in to the issue related around menthol tobacco and equity, right? So according to the Centers for Disease Control and Prevention, menthol in cigarettes creates a cooling sensation in the throat and airways when the user inhales it, making smoking feel less harsh. And because of that, it is very highly addictive, right? So those who use menthol cigarettes, especially young people, it is actually harder for them to quit attempts to stop smoking than potentially those who are using other types of cigarettes that are non-menthol. Next slide. And over the years, there have been targeted marketing strategies to actually market menthol cigarettes as a healthier, I'm putting that in air quotes, initiative. And these marketing strategies have been targeted in communities of color. So due to CDC data, this is where this has landed us. Young people and African Americans are more likely to smoke menthol cigarettes than other groups. 54% of youth ages 12 to 17 years old who smoke use menthol cigarettes, and the majority of African Americans who smoke use menthol cigarettes. 7 out of 10 African American youth aged 12 to 17 who smoke use menthol cigarettes. A higher percentage of Black adults who smoke started off by using menthol cigarettes. 93% of those reported that. Then their white counterparts who smoke, who only reported starting off using menthol cigarettes as 40%, 44%. Our non-Hispanic Black adults have the highest percentage of menthol cigarette use compared to other racial and ethnic groups. And again, this is largely due to marketing, right, in communities of color. This didn't happen just by happenstance. Other disproportionately impacted groups by the use of tobacco products in general and menthol in particular are our LGBTQ plus population and also our Hispanic population, and also women. Next slide, please. So this data points us to having to employ new strategies to combat these issues. And one is to really lean in and partner with and look at data from and help to uplift some of the recommendations from renowned organizations like the Center for Black Health and Equity. The Center for Black Health and Equity protests the marketing and sale of tobacco products to African Americans and alleges that the tobacco industry targeted the sale of menthol products to African Americans in particular. The center has a list of recommendations that include eliminating predatory marketing practices, educating youth and adult civic leaders about the strategic targeting of menthol products in communities of color, reducing the reliance on tobacco industry funding, and aligning tobacco-related policies with legislative efforts to eliminate social inequalities. These are the types of strategies that Delaware Cancer Consortium and its members can actually rally around to actually implement some of these here in Delaware. And that work has happened and continues to happen. Next slide. So I want to end with just sharing some of the resources that, through support from the Delaware Cancer Consortium and utilizing the resources of the Division of Public Health, have been developed in recent years to support the work that I have described. So we have some new cancer prevention materials that have recently been released. We have a vaping toolkit that is posted and available for everyone to access on healthydelaware.org. It includes cessation resources and a link to our quitline resources as well. In addition, our Bureau of Oral Health and Dental Services now has 4 cancer preventive fact sheets. We have a cancer and dental health fact sheet. We have an HPV, head, neck, and oral cancers fact sheet. We have a smoking, tobacco, and quitting fact sheet, which provide access to resources for how people can get connected to being able to quit. And we have smokeless, tobacco, and vaping fact sheet. These are just examples of how we're trying to ratchet up information and education to be pushed out broadly to our communities, especially our most affected communities that have been described during this presentation. So I appreciate and just want to thank everyone who is listening today. Many of those of you who are listening are in the trenches doing the work, right? Many of you are members of the Delaware Cancer Consortium, and I want to thank each and every one of you for your efforts. The slides that were shared today and the work that is ongoing is a collective effort from all of us, and we need to keep going. We've made some great strides over the last 20 years, but we also have a lot more to do as we can see. I appreciate the consortium's efforts and partnership as together we aim to improve life expectancy and the quality of life for all Delawareans. Now I have the great pleasure to turn things over to our Lieutenant Governor, Bethany Hall-Long. I just want to take a quick minute to thank the Lieutenant Governor for her long leadership role in the Delaware Cancer Consortium for its entire 20-year history. I also want to thank the Lieutenant Governor for her unwavering and continued support on numerous DPH initiatives that expand way beyond the work that she's been doing over the last 20 years with the Cancer Consortium, from health equity to her work with the Medical Reserve Corps, to her diving into the opioid crisis, to her support for our community health worker initiatives, to the tremendous role she played in our COVID-19 pandemic response. The list goes on and on. But on behalf of DPH and the entire state, we thank you, Lieutenant Governor. And I'll turn it over to you.
Thank you. Oh, we have it. Okay. Because if you're hearing me.
Lieutenant Governor, we just have a little bit of an echo. It may be that you have the event open in another browser tab if you close that. Otherwise, we can...
Do you need me to? Are we still echoing?
No, it just seems like maybe there's an echo due to if you have another device in the room that's joined to the conference or another browser tab, that's typically the issue. Oh, appreciate everyone's patience while you hang in there for us while we troubleshoot this.
Let's see. Thank you all for your patience. We're going to figure. Hi, can you hear me now? Hi, everyone. I am so apologetic, the fun of the virtual world. I wanted to just say very briefly, because I know we're on a tight schedule, having been the chair of the retreat for many years, I wanted to first start by saying thank you to Molly and to Cassandra. These numbers and what you've just stated are so important. Katie Conley, to your leadership, and I'm channeling this morning for those listening in who know I go back 20 years, Bill Bowser, his passion, and I'm thinking if our colleague Dr. Freilich was here to listen in, wow, he would be so proud of the work. I know we've got a remarkable keynote speaker who's about to jump on, but I just wanted to take a couple minutes to thank again those of you who've been in the trenches. I was there when it was a whisper of an initiative came into being a full council and had the chance to work with the research advisory committee. And now with our incredible Deb Brown working with the risk reduction group. And so thank you all for coming here today. You're going to hear from members of our General Assembly and panelists who are really making a true difference. But when you get that diagnosis, and I remember the very first meeting that we had as a group, the C word, the cancer diagnosis. I know I've had that experience with my family, like many of you, and we've moved the needle in the right direction. And today's focus on healthy living is so important that we stay focused on prevention. As we've just heard from Cassandra and the different data, it is so important also with equity. My heart is moved and touched when I reflect back to 20 years when we walked in those rooms. We started every session with a story from a real person and a lived experience. And I think of today when Governor Carney will come on this panel in less than an hour and talk about Governor Minner. She took her life's experience with her husband, Roger, turned it into action. And I think the one thing I would like to say very succinctly is we can act, and we are within the Cancer Consortium, but also in many initiatives. It doesn't have to take government. It doesn't have to take legislation. We know certainly our world changed in Delaware when we got the Clean Indoor Air Act, when we were able to do the Cancer Right to Know. And I know as a member of the General Assembly, having sponsored probably at least 30 to 40 pieces of legislation that came out of the Cancer Consortium, that we can make a difference in lifestyle. So thank you to Public Health, who's been working with us. I know Dr. Rattay and myself had a chance to work with the Healthy Lifestyles Committee. We had 14 policies, making recommendations, world high level health policy and all, making sure our early learning centers also had physical activity, no sugary beverage and sweetened items, little things like that. Or some of you through May 16th can join in the Lieutenant Governor's Challenge. If you haven't already, whether it's an individual, a workplace, a school, a setting, you can make a difference through healthy lifestyle choices, which will influence lower rates of cancer in our state. So again, I apologize for the technical difficulty that I think we've all learned to live with, but what do? We adapt. And that's what we've done in the state. So to Katie, to our predecessor, Bill, and to all of those, I want to say a sincere thank you. And especially as we honor a good friend, a mentor to me, Governor Minner, let's continue her legacy. And when you hear from our governor later, let's continue to put the foot to the pedal and really work in the community. And so with that, I'm delighted to turn this back so we can hear from our keynote speaker. So back to you, Katie or Mary Kane. We appreciate you and thank you for your patience.
Thank you so much, Secretary McGarrick, Associate Deputy Director Codes Johnson, and Lieutenant Governor Hall Long. You all were great giving our history, where we are now and where we need to go, and why prioritizing healthy living is so important. So I thank everyone who has been listening and is going to continue to listen. I just want to quickly go over the agenda so that you kind of have an idea of what is going to happen for the rest of the retreat. We're going to start with our keynote address, closing the gaps along the cancer control continuum to advance health equity among the nation's vulnerable low-income population. This will be delivered by Dee Calhoun, National Network Director of Self-Made Health Network. Dee is also a member of the Centers for Disease Control and Prevention's Consortium of National Networks to impact populations experiencing tobacco-related and cancer health disparities. Dee's presentation will conclude with a question and answer, so please be sure to jot down any questions you have. Following our keynote, you'll be engaged in a panel discussion on COVID-19, cancer screening, cancer prevention, and health equity. After this discussion, Dee Calhoun will offer her reflections on the topics the panel explored. Then the session will conclude with another question and answer opportunity. After this, we'll give you all a 5-minute break, and then we'll get back to our loving tribute to former Governor Ruth Ann Minner, with Governor Carney joining us. We will conclude our time together by walking through the key points of the Delaware Cancer Consortium's 5-year action plan. We'll be guided by Helen Arthur, Section Chief, Health Promotion and Disease Prevention for the Delaware Division of Public Health. So let's get started. I'd like to introduce Mary Kane, owner and president of Concept Systems, and she'll make the official keynote introduction. Thank you.
Good morning, everybody. It's a real pleasure to see everyone, at least virtually. My name is Mary Kane, as Katie mentioned, and we are really delighted to be involved in this 20th anniversary celebration of the Delaware Cancer Consortium. It's just a true pleasure for me because we have been involved since the very beginning, when it was just an advisory council, and it was really a wonderful and dedicated group of individuals, some of whom are still involved in this initiative, considering Lieutenant Governor, for example, and Governor Carney as well, have been involved throughout supporting this effort. It's really my pleasure to introduce Dee Calhoun, whom you have heard from Katie Connolly in terms of her background. So in the interest of time, I would love to just ask Dee to join us on stage and to provide her great thinking on these issues, which is so very, very clear and forward thinking as well. So Dee, I want to thank you on behalf of the consortium for joining us, and we are now ready to hear your comments. I do want to mention, as Katie mentioned before, that we will be having some questions after Dee's comments, and we'd love to have your questions for her, ladies and gentlemen. If you'd like to add into chat, people will be doing a couple of collecting of those ideas and forwarding them to us to ask. So there will be a little bit of a sort of a stepwise movement into those questions, but I want to make sure that you have that opportunity if the timing allows us to do so. So without any further nonsense from me, please, Dee, take it away. Thank you.
Thank you. And good morning, everyone. We're going to pull up our slide presentation. And I'm going to spend maybe a minute or 2 minutes on each slide. But the good news is that everyone will be provided with a complimentary copy of the entire slide set. So as everyone said, I'm Dee Calhoun, National Network Director for Self-Made Health Network. We're one of the CDC's members of the Consortium of National Networks with a focus on reducing cancer and tobacco-related disparities, specifically among populations with lower socioeconomic status characteristics. But we hope by the end of today's presentation, you learn a little bit more about social determinants of health and how you can advance cancer health equity in that context, and also address clinical community linkages. We hope that you also learn more about opportunities to reduce risk along the Cancer Consortium, especially from a low SES perspective. And we hope that you learn a little bit more about the intersection of cancer survivorship, health equity, as well as underlining socioeconomic status factors. So what we'll do is we'll begin by providing a general definition of cancer disparities as defined by the National Cancer Institute. And what's so beautiful about this new definition is that it includes one more component, and that's financial burden of cancer and health conditions, related health conditions. And that addition was added last month, at the end of last month. So cancer disparities or significant or persistent differences in cancer measures. And it ranges from the number of new cases, existing cases of prevalence, of course, mortality, survivorship rates, financial burden of cancer or related health conditions, as we mentioned, screening rates, and stage of diagnosis. The cancer disparities definition is also defined as outcomes that are improving overall. For instance, they're improving overall within the state, or they are improving overall within the nation. But there are some populations or communities that are still significantly impacted by these disparities as well. And what's so important about addressing cancer disparities and ultimately reducing cancer disparities is that the vision is to bring all families facing cancer to the same starting point so that they all have an equal chance of making it across the finish line. And this is important because once certain populations, for instance, low-income populations, are diagnosed with cancer, populations not only require a continuum of care, but these populations may also experience delayed stages of care, delayed access as well as treatment of care, or they may be significantly lost to follow-up altogether once they are diagnosed with cancer. Next slide, please. And so we mentioned the term low SES or low socioeconomic status factors. We wanted to provide just a few examples of what that really means. And this is important as you're working with partners, as you're working with other major stakeholders, and maybe some existing organizations who may be new to health disparities as it relates to low socioeconomic status characteristics. So some examples of populations with lower socioeconomic status characteristics includes, of course, populations with lower levels of income. Perhaps their income is at or near the level of federal poverty level. Populations who, of course, who are uninsured or underinsured, which means maybe they don't have comprehensive healthcare coverage once they're diagnosed with cancer to help them to minimize barriers, but to help them transition along the continuum of care with resulting in better outcomes. Low SES populations also includes populations with lower levels of educational attainment. And this is important as you consider populations with lower levels of literacy, populations with lower levels of health literacy, and populations with lower levels of digital literacy. And this is important because we still have pockets of communities throughout the country who may not possess access to the internet. But then once they do possess access to the internet, they may not have an adequate amount of interpretation skills in order to decipher what information is credible versus what health information is non-credible. And so as shown on this cancer control continuum, we want to just take one more look at this continuum through a health equity lens. And so as we began looking at the prevention sector of the continuum, it's important to not only identify high-risk areas by zip code, by county, but also census tract, but also examine areas that are characterized by persistent poverty. And we'll review that definition later on in today's presentation. It's also important to identify gaps and opportunities to develop, expand, and sustain patient navigation in all of these vulnerable areas as well. As we look at detection from a health equity perspective, it's important to identify vulnerable populations to not only increase awareness, but increase access and routine utilization of medical services, but also to ensure that there's linkages established to sustain persistent adoption of interventions within vulnerable populations and also vulnerable communities that are disproportionately or historically impacted by cancer disparities or other health disparities. When we're looking at detection from a health equity perspective, it's also important to evaluate the effectiveness of cancer screening programs, and that includes stratifying the data to ensure that we're not missing any gaps related to populations who perhaps may have a lower percentage of adherence to follow-up once there are abnormal cancer results. It's also important to examine disparities as it relates to accessing care and to promote coordination of care. And lastly, which is so important, to account for populations who may not have a routine source of care, and therefore they may not have a primary care physician to assist with management of other comorbid medical conditions. And this is so important as you think about our cancer, as we think about our cancer survivors who may also have other chronic diseases such as diabetes or hypertension or heart disease as well. Diagnosis, as we look at diagnosis from a health equity perspective, it's important to identify potential as well as actual barriers that may impact a patient's non-adherence to medical appointments. And then as noted in the Institute of Medicine's report, Delivering High Quality Cancer Care, charting a new course for a system in crisis, as shown on the next slide, there are additional factors within the diagnosis realm that are important. And so within this phase, the diagnosis phase, it's important to expand the breadth of data that's collected on cancer interventions that impact low-income populations, including our older populations. So for example, this may include our older populations who may be beneficiaries of Medicaid and Medicare health insurance. This also includes, as you'll hear throughout the presentation, our cancer survivors who may be diagnosed with other comorbid conditions, but as a result, the financial barriers may be very extensive, or they may perceive their barriers that they have cancer as well as other chronic conditions as insurmountable. And so this is why it will be important for the adoption of or enhancement of multidisciplinary teams to provide the type of support that's needed throughout the continuum of care, especially as it relates to our cancer survivors. And then as you'll see on the next slide, there are commonalities involving socioeconomic status factors that overlap with cancer disparities, as well as other disparities, including those disparities that have evolved or have been uncovered throughout the pandemic. And so as shown above, we have, of course, socioeconomic status characteristics that not only address a level of education and lack of insurance and our housing and income instability components, but it's also important to address the limited access to medical care, which we stated before, but a combination of these factors actually fuel underlying risks that are associated with cancers as well as COVID-19 disparities experienced among our low-income and other vulnerable populations. But the good news is that there are collaborative strategies that organizations may want to include or enhance or expand on. And they range from community engagement to the adoption of community clinical linkages. And that's why the role of community health workers is so important. It also additional solutions or strategies includes ensuring that we address populations who may have lost their health insurance because they're newly unemployed. In some instances, we may have cancer survivors who've never been unemployed, and so unemployment is new to them. And this is our opportunity to ensure that we engage them and navigate them through the entire healthcare system in the face of limited healthcare insurance. And when we say engage them throughout the entire continuum of care, this means that we ensure that we engage them after they're diagnosed, and we make sure that they are connected to a primary care physician, as well as, of course, the oncology team. But we want to make sure that we continue to monitor them and ensure that we provide the types of support that are needed to minimize cancer recurrence as well. And as you see on the next slide, you'll see on the next slide how the COVID pandemic has also impacted cancer outcomes. And so our low-income populations and other populations with low socioeconomic status characteristics experience higher rates of cancer mortality compared to other populations. They face, of course, a number of barriers relative to preventive care, early detection, a lot of financial, maybe structural obstacles, and some of those may be perceived because they just don't know, and then some of those obstacles may be actual barriers as well. It's also important to know that according to this projection, delays in cancer screening, diagnosis, and treatment due to reduced healthcare access will likely result in a short-term drop in cancer diagnosis, followed by an increase in late-stage diagnosis and preventable cancer deaths. And this is also attributed to the one factor that I mentioned previously, that we have an unprecedented amount of Americans who, for the first time, maybe they've lost their job due to the economic impact of COVID as well. And so as a result of losing their job, this may impact their decisions to delay seeking care or to delay seeking information about just cancer screenings, because they may fear that once they're diagnosed, they aren't able to afford the medical support, the expenses associated with the medical support needed in order to have a healthier outcome. However, on the other hand, the COVID pandemic presents an opportunity for all of us to seek and explore solutions to engage traditionally difficult or harder to reach populations who may not have a routine source of medical care. And then to also ensure that some of these solutions are applied to not only cancer survivors, but cancer survivors who also have other comorbid conditions. And so some of those solutions and opportunities are featured on the next slide. So the most current version of the 10 essential public services motto was revised in 2020. And this is the first time that it includes domains that are centered around equity. And so for the sake of time, I won't go through or review all of the domains, but you just wanted to ensure that you all were able to see this beautiful motto that's centered around equity. But what's so important as well about this motto is as you look at essential public service number 7, it's assuring an effective system that enables equitable access to individual services and care needed to be healthy. It aligns really well with the wonderful relaunch of the 2020 Cancer Moonshot National Initiative, goal number 2, which is facilitate equitable access to cancer screening. And all of this is a part of course, the President's Cancer Panel as well. And you'll see as part of your complimentary slide said, we as a national network are also launching a webinar series beginning in May through July, featuring a number of experts from across the country. And so you're welcome to look at that information later, but we wanted to make sure that you were aware of it, just in case we run out of time. All righty. And so within the President's Cancer Panel report is, of course, a goal number 2, and it features, it's wonderful. It has a great emphasis on community health workers as we strive to achieve this goal, which is facilitating equitable access to cancer screenings. And it takes into account not only identifying barriers associated with cancer screenings, but also identifying or cultivating partnerships so that vulnerable populations who are either due or overdue for cancer screenings are engaged. It also emphasizes the importance of establishing sustainable funding models for community health worker programs to ensure that they meet their maximum potential. And we'll see additional examples of social determinants of health, because I know it's a concept that everyone hears. We wanted to make sure that everyone has a general understanding of what we mean by social determinants of health, and that's featured on the next slide. And so on the next slide are just a few examples of some social determinants of health that all ultimately impact the health status of populations, including populations that are at risk for cancer, populations who are diagnosed with cancer, vulnerable populations that are diagnosed with cancer as well. And so as we just take maybe 1 or 2 examples from this model and provide context, this information will be helpful as you're working with additional partners as well who may be new to health equity or social determinants of health. And so as we look at economic stability and employment, this is important because we may have some low income populations who maybe they are full-time workers, but once they're diagnosed with cancer, they're unable to work full-time. So their status may change from full-time to part-time. As a result of that status change in their employment, their health benefits may change as well. And this may impact maybe their treatment 5 years down the road because they may not have they may not have adequate financial reserves to help sustain all of the medical costs that are associated with cancer treatment. As we look at medical bills, this is sometimes a factor that impacts decisions made by low-income populations. There may be hesitancy present because they fear that if they are diagnosed with cancer, then they will receive a medical bill that their health insurance does not cover. So as a result, they will have out-of-pocket costs or additional expenses that they can't afford. And so as a result of all of these factors, they may hesitate on even taking the first step to participating in cancer screenings, or if they're abnormal test results. and they are, impacted with the bill, this may impact their decision to seek treatment. As we scroll a little bit across to maybe the neighborhood and physical environment, I know it was nice to hear about physical activity, because sometimes the environment that one lives in may impact whether they participate in outdoor physical activities, which ultimately could impact whether they can reduce their risk related to cancer, but not only cancer, but other chronic diseases as well. Zip code and geography, we mentioned that earlier in reference to aligning the data to ensure that you continuously monitor and capture not only the data, but maybe the identify data gaps as well. Literacy is important as we look at education, and that's looking at literacy as well as health literacy and digital literacy. Food is important. This is very important as well, because we have a number of low-income populations who reside in areas that are characterized by food deserts. And then, as we've learned with the pandemic, a number of low-income populations reside in communities where there are pharmacy deserts as well. So they don't have access to that additional medical person on the team to provide them with education about the importance of participating in cancer screenings, or the importance of adhering to cancer treatments, or the importance of assisting them with identifying what financial barriers exist to identify maybe additional solutions. Community and social context is important. And so community engagement is listed. And then this also entails the importance of community clinical linkages and ensuring that we link communities and populations to, for instance, community health workers. And then, of course, our healthcare system, this is very important as well, especially when we consider the importance of ensuring that primary care physicians are linked to members of our oncology team, and there is the development of a multidisciplinary team for every single cancer survivor. And then lastly, policies as well as practices in non-health sectors also impact health equity. So additional background information on social determinants of health is shown on the next slide. And so the Commission on Social Determinants of Health Conceptual Framework proposes that interventions and policies to reduce health inequities must include policies that are specifically crafted to tackle the mechanisms that systematically produce an inequitable distribution of social determinants of health among vulnerable populations, but then it also must address or include context-specific strategies at different levels. And so for the sake of time, we won't go through this framework, but you'll have it as a reference as you're working with partners. And so additional determinants of health also, of course, impacts cancer disparities relative to cancer prevention and survivorship, as shown on the next slide. And so this next slide is just a framework from, of course, the Institute of Medicine, now known as the National Academy of Medicine, that was developed to address cardiovascular diseases and also applicable to cancer prevention for 5 common cancers, which is so wonderful. And so what's so important about this framework is that it includes recommendations that address policy interventions and environmental interventions, which is another social determinant of health, but we didn't get a chance to go through that part. The recommendations include addressing environmental and policy interventions as the key to initiating, but also sustaining favorable change, and also thinking across multiple levels of influence and making use of existing tools, but also tailoring additional tools as additional gaps relative to health equity are discovered. And then lastly, addressing your local context and policies undergirded by the development or enhancement of non-traditional partnerships, all to enhance health equity. And so solutions to most social determinants of health require changing systems, policies, and or implementing a policy that affects an entire community or system. And as a result, it remains important to work at different levels, as shown in this wonderful model, in order to sustain health equity. And so additional information about changing the trajectory of cancer as it relates to social determinants of health is shown on the next slide. Sorry about that. We'll make sure we get through all our slides, as many as we can for you all. And so social determinants of health, of course, affects the trajectory of cancer, from prevention to cancer incidence to access to, what's very important, to timely receipt of cancer treatment, including if cancer recurrence, if it occurs as well. And so we just want to make sure you view this model because it also emphasizes the importance of addressing comorbidities among cancer survivors. And so disparities affecting populations that are diagnosed with cancer, as well as just cancer survivors with comorbidities, can be attributed to either one or more factors at different or multiple levels, which is shown on the next slide. So cancer disparities occur across the cancer control continuum. And so this framework is beautiful because it includes a rural health perspective as well that can be applied to medically underserved areas. And medically underserved areas include both rural as well as metropolitan areas. And this framework takes into account your micro level factors, such as your individual factors, but also your macro level factors as well, which includes context. And your context may be the environmental context, your health system context as well. But then what's also important about this model is it takes into account the importance of addressing perceived and actual barriers among low-income populations, especially if they receive like an abnormal test result, or all of a sudden maybe they receive that cancer diagnosis, and so they may have all of these perceived ideals in their mind, but these perceived barriers may not necessarily translate to actual barriers. And that's why it's so important, and that's why the role of community health workers is so important as well. And then also poverty is another term that you want to ensure that partners, major decision makers, and all of your communities that you're working with have a general understanding of what is meant by poverty. It's nice to, it's very helpful to address the understanding of poverty, because this is one way to also dispel myths and biases and assumptions about low-income populations. We'll see it on the next slide. So this next slide just takes into account persistent poverty versus current poverty. Sorry about that. And so as we just think about the data, the overall cancer mortality rate in persistent poverty counties is higher at 201 deaths per 1,000 people compared to 179 deaths per 100,000 people in counties not experiencing persistent poverty. And persistent poverty counties usually entail or consist of a larger population of minorities, a population of households that include children that are under the age of 18, higher levels of populations with lower level of education attainment, and that includes maybe higher rates of high school dropouts as well. Higher rates of uninsured and underinsured populations, higher rates of unemployment rates as well. And it's important when you capture unemployment rates to also try to decipher your unemployment rates generally, but also your populations who experience unstable employment. So maybe they're employed maybe 6 months throughout the year, or they were employed 6 months throughout the year, and then all of a sudden they're diagnosed with cancer and they're unemployed as well. And then on the other hand, there are additional, and so all of these factors combined also impact, of course, whether populations may participate in cancer screenings or treatments or adhere to just medical recommendations. Now on the next slide, there are additional factors that impact cancer outcomes. And so this framework just entails opportunities to influence the process of care along the cancer continuum. And what's so wonderful about this model is that it emphasizes the importance of addressing multi-level interventions. And that includes, for example, you may have in order to improve health equity, it's important to address multi-layers of interventions. And so those may be interventions that originate from different systems. So you have an activated patient, a healthcare team that's activated. You may have a community that is also more knowledgeable because of the work of community health workers as well. And so by adopting a multi-layer intervention approach, then you're in a position to also advance or improve influence among vulnerable populations because of these different origins of interventions as well. And then it's equally important to identify or uncover multi-level barriers that are seen on the next slide that may impact decisions made by low-income populations. So examples of a few of these barriers are listed above. And they range from early diagnosis to also potential interventions to strengthen early diagnosis. And what's so important about these barriers is that these barriers provide insight into potential areas where community health workers can help to support low-income populations and other vulnerable populations, because it's very important for populations to move to a point where once they are diagnosed, that they receive treatment less than 3 months after they have been diagnosed. And it's also important to ensure that programs are developed, but then also tailored accordingly based on lessons learned involving community health workers and timeliness of care and accessing care as well. So on the next slide are just additional opportunities to influence the process of care along the cancer continuum. Good. Okay, so shown above are just a few more examples to influence the process of care along the cancer continuum, and especially what's especially important about this model is that it has delineated transitions of care. And so when you're delineating transitions of care, this is movement either across the cancer continuum that involves several types of care, or transitions between this continuum as well. And these are all opportunities where community health workers have a significant role to impact the timeliness that's associated with these. And so what's important as well is that each type of care consists of multiple small steps, and there can be interfaces between them as well. And so in addition, there are factors associated with the different types of delays in cancer screenings as it relates to the detection phase that may occur either simultaneously or different levels, as you'll see on the next slide. And so on this next slide, it's so important to note that at all stages, barriers can reduce a patient's chances of being diagnosed and treated quickly. And so as we just, for the sake of time, just pay special attention to access delay component on this model, this is one ideal component for community health workers' roles to be expanded or enhanced in order to improve and sustain health equity, especially and cancer, and to improve cancer disparities, especially among populations with lower socioeconomic status characteristics. Next slide, please. So this next slide is just another depiction of examples that features just a collaborative care model, but it provides a wonderful emphasis on realized care. And so I'm not going to go through this for the sake of time, but I want to make sure that you all were provided with this model as well. And there's an emphasis on not only evidence-based interventions and guidelines and coordination of care, but also the importance of ensuring that this is a continuous model. Next slide, please. And so this next slide is just another example of shared care. And what's so wonderful about this model is that it entails that there's care supported along the cancer continuum, but it's also beneficial to ensure that registered dietitians are included to provide support to cancer survivors overall, including cancer survivors with comorbid or multiple chronic conditions, including diabetes, hypertension, heart disease, stroke, and COPD as well, because we may have some cancer survivors who may be, long-term tobacco users, and they may, receive a diagnosis of COPD as well. And it's also important to adopt a multidisciplinary model so that because the multidisciplinary team can lessen the perceived or actual barriers or responsibilities and burden that's associated with cancer diagnosis, especially among our cancer survivors who are considered low income or considered part of the low income population. And just another example of a multidisciplinary team approach is featured on the next slide. And this is just a beautiful matrix. We won't go through this for the sake of time, but I just want to draw your attention to my left, maybe your right side of this matrix. And it highlights the importance of community navigation, coordination with community health workers, community outreach, community-based screenings, and then centered around our nurse navigators and our patient navigators as well, but taking into account other factors that may influence a cancer survivor's decisions to access treatment at a certain time or participate in certain survivorship-related recommendations at a certain time. And so on the next slide are just a few more examples of barriers associated with patient navigation. And what's so important to note about the patient navigation is that its origin is rooted in health equity and responsiveness to entrenched barriers to care for underserved patients with cancer. And so it's an important tool for achieving health equity and delivering outstanding cancer care to every patient, every day, everywhere. And so this next slide just provides just some general information about maybe some steps organizations may want to consider as they are implementing a patient navigation program with a health equity lens. And just to draw your attention to maybe one of these examples, it includes ensuring that the establishment of the patient navigation programs entails addressing social determinants of health and barriers as well. And that includes maybe different types of barriers, financial barriers that are seen on the next slide. And so this next slide just provides ideals of different types of financial barriers that a patient, a cancer survivor may encounter, and some of these may be perceived barriers and some may be actual barriers as well. And so we just want to make sure this was a part of the presentation so that as organizations are developing cancer survivorship plans, these cancer survivorship plans take into consideration these factors. And then the next two slides just provide just examples of questions that organizations may want to consider as they are thinking about either enhancing or expanding their health equity efforts, or they're in the implementation phase and they want to enhance their health equity efforts as well. And so we won't go through them for the sake of time, but I'll just read one or two of the main questions, but you'll have them as guidance to help guide you as well. So one is, how can funding decisions advance our health equity efforts so that they align more with the health equity needs in communities? How can we integrate health equity into our products and service offerings so that they're more accessible and maybe are provided, or maybe delivered with better quality as well? Because even low-income communities and low-income populations, they still want to ensure that they're receiving quality care, regardless of whether they're paying for it or not. Additional questions are featured on the next slide, and they address maybe what existing partnerships do you have with populations experiencing health inequities, or what current partnerships or coalitions members that exist, but also represent communities that are experiencing health equities, and what tools or resources can we use to identify them, and of course, ensuring that those resources are tailored accordingly. And so for the sake of time, the next slide and the next three slides are intended to ensure that you all are equipped with additional resources to guide you through some of this work as well. And then, so on this exam, thank you so much. So it's 1, 2, and 3. I won't go through all of them, but one of the resources is, for instance, protocol for responding to and assessing patient access risk and experiences. You also have social determinants of health screening guides from the American Academy of Family Physicians. Also, additional resources from the American College of Physicians, as well as a case for patient navigation in lung cancer screening among vulnerable populations. And with that being said, I want to honor everyone's time and ensure that you all have a wonderful meeting. Thank you so much.
Dee, I'm so impressed by what you have covered. And one of the things I absolutely love about what you've shown us is the range of models that you've shown that are promising practices, best practices, and the integration of those that really help us to think about tools. So this is a very practical approach that you took, which I really, truly appreciate. So individuals who are listening can look at your slides, which you're making available. And we also really appreciate that, so that they can then ask themselves the questions, what about these models? What about these interrelationships of models are suggesting the opportunity for me as a partner, as a potential partner, to make change in the community, especially around the issues of promotion of health across the spectrum. And so we have very little time for questions, but I just wanted to ask you a quick one around the cancer prevention and treatment that now COVID has affected, from reduced or delayed access to screening, to diagnosis, to delayed or modified treatments. Do you think that this is mostly a short-term to intermediate-term effect, or would you say that it's more systemic and may affect cancer incidence and mortality numbers further down the line and for a longer period?
Yeah, great question. I think it's the latter. It's more of a systemic effect, and that's because even with the, as we are, which is really nice, as the COVID pandemic is slowly subsiding, which is wonderful for the nation, we still have a certain percentage of the population who are considered long haul COVID.
Yes, yeah.
And so these are, the research is going to be very helpful, because it's going to be, research will allow us to stratify the data to see maybe what percentage of the long haul COVID populations or cancer survivors versus, what percentage of them or cancer survivors with our chronic diseases. So cancer survivors with diabetes, heart disease, Alzheimer's as well, because that's going to be important as you're thinking about maybe future booster shots as well, but also our long haul COVID populations who are just have no chronic diseases as well. But then it's also going to be important for our researchers, as well as other sectors, to continue to monitor cancer recurrence, because we're still taking into account the fact that the same populations, or the majority of the populations who were disproportionately impacted by other health disparities prior to the COVID pandemic, are still going to be impacted after the COVID pandemic subsides. And we want to make sure that we take into account cancer recurrence rates, and then also stratify that data as well by, for instance, health insurance status, those who are underinsured versus those who are uninsured, but also our genders, because for a number of our cancer, it's wonderful. For a number of our cancers, it's very helpful to stratify that data by gender to see maybe if there are pockets in the community, if there are certain communities where our male populations are losing their lives due to cancer. And then ensuring that we work with various sectors to create a greater emphasis on men's health. And then, look at additional zip codes and census tracts to see where other gaps and pockets exist. But this is also an opportunity, which is really wonderful, for just us as all sectors to explore or to maximize population education efforts in the same areas where maybe new COVID vaccination sites were established, and maybe our cancer screening sites weren't even established.
Absolutely. Yeah.
This provides great opportunities to continue to enhance, to engage those communities. And that's the beautiful work about community health workers, because, if sustainable and effective models and creative models can be established in those areas, they can impact cancer and a number of other conditions that have been significantly impacted by this health disparities.
Thank you. And that brings me to the fact that I had several questions that I wanted to ask you about community health workers, but in the interest of time, I would love to ask you, if you wouldn't mind, if we had the opportunity after the retreat for me to send some questions to you that you might be able to answer, and then we can post them to the people who are attending, if that works for you.
That's a wonderful idea.
Okay, thank you so much. I truly appreciate it. And I'm sure everyone else will as well. Let's move on then to panel, because I'm very excited to hear what Dee had to tell us today, and then how we're going to be following up with 3 people who are very involved in what's going on. And we want to make sure that the panel has the opportunity to share their thinking. And then I'm hoping to have some time for a few questions as well. So when we think about the effects of systemic health inequities that are leading to disparate and inequitable health outcomes that are now compounded by COVID, that allows us then to think about these compounding effects from our speaker and then also from the panelists that they'll be coming forward with. And I'm delighted to introduce the panel, whom you will meet in short order. Representative Kendra Johnson of the Delaware House of Representatives has dedicated her entire career to serving individuals living with disadvantages and challenges. She's from Chester, Pennsylvania, and is now firmly entrenched in Delaware as one of our representatives. She's an executive director at Elwyn, which is one of the country's oldest not-for-profit organizations, and she served on the board of directors at the Chester YWCA and is a member of several organizations and is a board president of the Ability Network of Delaware, which is an advocacy group, as many of you know, that focuses on not-for-profit organizations. Representative Johnson holds a master's degree in human services from Lincoln University. Scott Siegel is a licensed psychologist and the director of population health research within the Institute for Research on Equity and Community Health and the Helen Graham Cancer Center and Research Institute at Christiana Care. Dr. Siegel works collaboratively with many multidisciplinary experts to address the leading behavioral risk factors that contribute to cancer disparities and population health outcomes. Dr. Siegel is also involved with appointments at University of Delaware, Sidney Kimmel Medical College, at Thomas Jefferson University, and the Wistar Institute. Ms. Nicole Pickles is Executive Director of the Cancer Support Community Delaware, a state nonprofit organization that provides emotional, physical, and financial support services to people with cancer and their loved ones. Ms. Nichols is a cancer survivor herself and was first a member of the board of directors of the organization she now runs. She has been involved with financial advising in the past and also close to my heart was involved with the Joffrey Ballet at Chicago as a development officer and has worked with ACS in Atlanta and Chicago. Nicole holds a BA from Emory University. So while we go forward now, it's my pleasure to first invite Representative Johnson, who will then be followed by Dr. Siegel and then Ms. Nichols. So it's truly my pleasure to invite Representative Johnson to begin the panel with her comments on prioritizing cancer health equity at the legislative level.
Mary, thank you so much. Thank you all for having me this morning. So yes, prioritizing cancer health equity at the legislative level. This morning, what I will do is just have a brief discussion with you related to change and structures and silos and working outside of those silos for the greater good of Delawareans. Specifically, what I will do is I will highlight the work of the Delaware Legislative Black Caucus's African American Task Force. And the African American Task Force was created to identify gaps and support research and make recommendations to the General Assembly as well as the governor. And as you see here, we have a slide that essentially just gives you some very high-level information related to the African American Task Force. So first, I serve as the chair of the African American Task Force. The African American Task Force was created fiscal year 21 and grant and aid legislation. And this task force was charged, as I said, to research, to collect, and put forth recommendations. And in this particular task force, the areas that we were looking at were education, health, housing, economic development, community empowerment, environmental justice, violence, and criminal justice. Next slide, please. I am going to focus solely this morning on the health and welfare subcommittee. But what I did want to bring to your attention, and I hope that if time allows, or if you have the interest, that you go back and actually research the information related to the African American Task Force, our structure, and the multiple subcommittees that we had. So here we have the economic opportunity, safety and justice, infrastructure and environment, and then finally health and welfare. And sticking specifically with health and welfare, myself and Representative Minor Brown, we were the chairs for the Health and Welfare Subcommittee. This subcommittee ultimately ended up having 4 research groups that explored the disparities involving African Americans, Black people, brown people, and access. What I will do today is I will share with you a scenario that speaks to, actually it's one of the recommendations and portions of the recommendations. So let me give you additional information. So I spoke earlier about the recommendations having to go before the entire body for approval. What I will do today is I will connect one of our recommendations, which has not been set forth before the entire body, to give you an idea of a scenario and how you can work through these things to create better outcomes for individuals. So the scenario that I will discuss, and I'll speak slowly to give you an opportunity to just really process it as I then get to some very salient questions related to this. So it goes like this. We should provide targeted outreach and marketing to clinicians and healthcare centers and community partners and patients on health screenings related to cancer, related to counseling and education, weight and high blood pressure, and of course, cancer survivors. And in doing that, we also call on partnerships with entities within the state, for example, DHSS. So in thinking about that, the question is, so what is needed to create that high level thought that I just put out into the universe? How do you do that? And when I think about it, I'm like, my goodness, the African American Task Force is the perfect example of how you make that happen. However, on the opposite side of that is this. The African American Task Force was a result of all of the things that were happening in our country at that time involving the George Floyd events. So the George Floyd events were the catalyst for the creation of the African American Task Force, as well as the Law Enforcement Task Force. And we hope and pray that circumstances like that don't occur again. However, I have to acknowledge that those events were the catalyst for the start of looking and researching, and then ultimately coming up with recommendations for the people of Delaware. And then you add to that COVID. Wow. And COVID just literally blew all things out of the water. What I'd like to do now, just in thinking about that scenario, give you an example of how portions of that scenario has already occurred within our state. And what comes to mind for me? George Floyd, civil unrest, COVID, people are not receiving the level of care and service and access that is needed for so many things, from testing to receiving the immunization. What we saw and what we have learned, and I hope that while COVID has definitely been, I really have no words for it. My hope is that we learn the lessons from what has happened as a result of COVID. And one of the lessons that I believe our state has learned, and we will continue to grow as a result, is this. What we found is we created partnerships. Once we realized that we were not addressing the needs of individuals that are not privileged, that don't have the resources that some may have, because the state of Delaware is diverse. And what we did during that time is we created partnerships and collaborations with the governor's office, with lieutenant governor, with DHSS, with faith-based communities, with community partners, legislators, and other leaders. And what happened is that we stepped outside of our silos and we began to interact as one coordinated force, one coordinated, amazing force. And we were able to create good outcomes for individuals. Now, I must be completely honest here. It's not like we woke up one day and said, we're doing this wrong and we're just going to right the ship. No, we had to see the individuals who were being left behind based upon our planning. And then we had to have the difficult conversations to get us to the point of acknowledging that there are flaws and shortfalls in our systems, and that we weren't thinking about all Delawareans when we put a particular plan together, that our thinking, while we wanted to get information and resources to the masses, we were really scratching the surface and meeting the needs of those individuals with privilege and resources. And my thought here is that as we attacked that, so should we attack and address all things related to cancer disparities and disparities across an individual's lifespan. And I look at that as just the perfect example, because we all came together. We realized the interconnectedness of all systems and all people, and ultimately were able to make some good things happen as a result. So when I think about impacts and legislation and how all of these things lead to healthier communities, how we are all connected, the residents, the medical communities, as well as government, you also have to think about what that takes, right? You have to be intentional. You have to acknowledge the disparities and the shortfalls throughout. But then after that, you have to commit. You have to commit through change, through partnerships, through legislation, and through funding, adequate funding. When I think about legislation, and I'll try and connect all of this to the African American Task Force, the recommendation and recommendations that will come from the full body task force, that all of these things occurred and will occur because we are all working together for the greater good of communities. And while some individuals will think about the African American Task Force and thinking it's solely for the needs and the benefits of African Americans, of Black people, of Brown people, this is also touching every single Delawarean here in our state. And with that, when one of us is touched and helped and elevated, it touches, it helps, it elevates every last one of us. And finally, I will say this. In addition to the many recommendations that will ultimately become a part of the African American Task Force full recommendations, there is also a commitment that this not be the beginning of a thing that starts and stops, that this acknowledgement remains intentional and is weaved through every single thing that we do in our state, from legislation to policies to collaboration and to funding. And with that, I will stop talking. I thank you for this opportunity. I know I went through a lot really quickly. It's a lot of information. Again, I say to you, if you would like to know more information, please go on to legis.delaware.gov, get additional information, and look at all of the work that these task forces have been working on for the last 2 years. And look for more to come as we work hard to address and reduce disparities and access. Thank you so much.
Representative Johnson, thank you so much for a very both anchoring and future-looking way of us to look at this. And I really loved your comment about the fact that when we think about lifting up the African American experience, the experiences of Black and Brown people and others who are disenfranchised, then the question really is, how does that benefit everybody? And to me, the benefits are obvious. So thank you. I want to do a little bit of a time check. We have two really remarkable speakers who are going to be joining us individually in just a moment. But I do think that we want to thank Dee in particular, and we're going to begin to just continue to move on into the panels. We will be saving questions at the end, and Dee may have a question at that point, but we will be looking at the clock pretty specifically. We'd like to wrap up the panel and any questions we might have the opportunity to ask. So we need to end at 10:50. So that gives us 20 minutes for the additional two experts, as well as perhaps a few questions. We will see how lucky we get. It's my pleasure now to say it's just been such a joy to get to know the panelists a little bit during this process and to learn about the expertise that each brings to this issue. And so it's my pleasure now to introduce Dr. Scott Siegel, who will describe some of his recent research and its relationship to risk factors. So he's going to be talking about building upon past successes and targeting racial disparities in breast and lung cancer in particular. So thank you, Dr. Siegel, and it's all yours.
Good morning, thank you. And if we could pull up the slides. As a psychologist, I'll tell you, I know how to keep my eye on the clock, so I hope to get us back on schedule. So as you said, I want to speak about building on the past successes that this remarkable consortium has had over the last 20 years and focus on where we really see an opportunity to move forward in terms of addressing racial disparities in breast and lung cancer. So why these two cancers? On the next slide, I'll share with you statistics that were just released by the American Cancer Society to show that among Black men, lung cancer continues to be the leading cause of cancer mortality. Among female or Black women, breast cancer actually just supplanted lung cancer and is now the #1 cause of cancer mortality. Next slide, I'll talk a little bit more about each of these cancers, beginning first with breast cancer. We know in Delaware, like is true throughout the nation, that despite similar incidence rates between white and Black women for breast cancer, mortality rates for Black women are about 40% higher. And here in Delaware, if you look among younger women specifically, that's even worse at 56% higher rates. We know that Delaware has among the highest rates of triple negative breast cancer in the country. And triple negative breast cancer, as many of you know, is a particularly aggressive subtype that disproportionately affects Black women. And what we just learned last year is that Delaware is #1 in the nation for alcohol attributable breast cancer. Not everybody is necessarily aware that alcohol is even a risk factor for breast cancer, which it is. It's well documented. But in Delaware, the estimates are that alcohol contributes to nearly 1 in 5 breast cancers, leading the country. Next slide. We were interested in better understanding what was going on with triple negative in Delaware, and we focused here in a report that just came out earlier this year in Cancer Epidemiology, Biomarkers and Prevention, where we looked at hotspots, whether there were any hotspots for triple negative breast cancer. And what our analyses showed was that there were, in fact, 2 hotspots. So Delaware, which happens to be among the highest rates of triple negative in the country, and then within Delaware, we know that most of those cases are in Newcastle County. And then at an even more granular scale, we can see that there were these 2 hotspots in Wilmington and then the Bear areas. And then there were 2 cold spots in northern Newcastle County and North Wilmington. Next slide. So what are the possible next steps we want to take knowing that there are these hotspots? First, we want to focus our outreach efforts here. As we've already heard, the navigation and other outreach activities in the state has been a huge part of the success in addressing disparities, beginning with the colorectal work and through present. But now we can be even more targeted in our outreach. And this is particularly true in the time of COVID, where we know that screening for breast cancer, while down because of COVID, has disproportionately affected certain groups, including Black women, as this recent report shows. So we want to really double down on our outreach, and we can be even more targeted, guided by our results. Next slide. We can also address unhealthy alcohol use, as I discussed, and also obesity, another risk factor for breast cancer in primary care. Again, because of COVID, these are even more urgent. We know that for certain groups, COVID contributed to both an increase in alcohol use and weight gain. Next slide, please. And we can also, building on the talk that we just heard from Representative Johnson, we can consider policy approaches to further reduce alcohol use and obesity, which I'll show a little bit more on the next slide. So there's a lot going on in here, and in the interest of time, I'll be brief. But what I'll just say is in the left panel, panel A, you can see that here the Wilmington hotspot is still demarcated by the dashed lines. But what the dark red here shows is the rates of alcohol use disorder among Christiana Care hospitalized patients. You can see that there's a very strong correlation between where we see high rates of unhealthy alcohol use and one of these triple negative hotspots. Those white dots, by the way, happen to be liquor stores, and you can see that they are disproportionately overrepresented in the Wilmington area. And we know that communities that have a higher density of liquor stores have higher rates of unhealthy alcohol use. It allows for easier access, heavy marketing, etc. On the right panel, in panel B, we looked at obesity. And here we saw obesity was perhaps more of a concern in the Bear hotspot. And in this map, we see the white dots represent fast food restaurants. What we're not showing is that there are also fewer, healthier food options in both of these hotspots. Both of these issues, the availability of healthy food and the overrepresentation of liquor stores in certain communities, can be addressed through policy as they have been in other parts of the country, and would be happy to discuss that further. Next slide. Turning now to lung cancer, we know that lung cancer is the leading cause of cancer mortality overall, both here in Delaware and nationally. We know that Black individuals are less likely to be screened for lung cancer and less likely to be advised to quit smoking. And when Black individuals who smoke are offered smoking cessation services, we know that they are less effective. Next slide. So what are our possible next steps? What can we do about this? Well, for one, we definitely want to equitably increase access to lung cancer screening. These data here show that in Delaware, that Black individuals are more likely to be diagnosed with an advanced lung cancer. And this is something that lung cancer screening can certainly help to improve upon. Next slide. We also want to prioritize access to smoking cessation treatment and make sure people are provided personalized treatment options to improve their outcomes. So what do I mean by that? Next slide. I don't have a lot of time to get into this, but what I can tell you is we have ongoing research, which is to see if we can't translate prior research done in well-conducted clinical trials, that if we give patients a very simple commercially available blood test, we can quickly assess how quickly their body metabolizes nicotine. And the past research has shown that if you provide slower metabolizers of nicotine with the nicotine replacement patch and faster metabolizers with the varenicline, you can both maximize outcomes in terms of cessation and minimize side effects. For the faster metabolizers, a group that has been notoriously difficult to help quit smoking, we actually see a quit rate increase by as much as 5x. That's remarkable. And there's, again, an important policy issue here. Delaware Medicaid requires that patients must first fail nicotine replacement therapy to qualify for varenicline. So if we're going to implement something like this, we might consider adjusting our policy to allow patients who would benefit from varenicline the first time to be able to access that when they're ready to try quitting. Next slide. And so further, we can also consider policy approaches in addition to the Medicaid approach, similar to what I was discussing previously with the breast cancer case study in terms of tobacco retailers. Next slide. These are results from another recent report we put out. And here we're showing you Wilmington. The darker red areas are where we have patients who are smokers, and the white dots are stores that are licensed to sell tobacco products. Critically, many of these stores are embedded directly in people's neighborhoods. These are residentially zoned areas. These are the places that kids walk past you on their way to school, tobacco being sold in the very stores that people are going to buy their weekly bread. So we know that for someone who would like to quit, that those temptations and those cues to smoke are very, very difficult to resist. So more policy implications to consider. Next slide. So just to wrap up, I would propose we have a new playbook. We can engage in even more targeted outreach to improve screening and risk reduction, both through mammography or lung cancer screening, as well as addressing things like smoking itself, alcohol use, and obesity. We should consider policy approaches to make our neighborhoods healthier, to help the people we're serving actually achieve the goals that they say they want to achieve, but their neighborhoods sometimes undermine. And finally, it's just so critical that we continue to use research to evaluate what we're doing and continually improve our approaches. And with that, I'd like to conclude my talk. Thank you very much.
Scott, thank you so much. I really appreciate it. And I see the challenges of making sure that we're using all sorts of different kinds of data to increase the opportunity for people to understand what treatments would be best for them to help with cessation and better health. I'd like to invite Ms. Pickles to join us. Our third panelist helps us to see the personal side of cancer and the survivorship's challenges for those who are survivors and for those who take care of them or who work or care for them, I should say. And so she's going to describe the work of her organization, the Cancer Support Community Delaware, and services in the era of COVID and what has changed and what the effects might be thought of as being. So thank you, Nicole.
So, Nicole, I think we've got your mic turned off somehow. If you don't mind checking that. It might just be in the settings at the bottom under audio. Just make sure that the correct microphone is selected. Thanks, everyone, for holding on for us. Not quite yet, nope. No, not yet.
How about that?
Yeah, that may be working, although it's a little scratchy. Let's hear it one more time.
Good morning,
Yep.
everyone. Okay, I'm so sorry. Good morning, everyone. I'm Nicole Pickles from Cancer Support Community Delaware, and I'm happy to be here to talk about cancer support community and what we have seen in the last 2 years with COVID. So I'm going to start with discussing the experiences of individuals that CSCDE has served over the past 2 years. Would you please go to our next slide, our benefits of virtual services. So our benefits of virtual services, if you see our third quote there, which really talks about who we are and really summarizes what our participants have seen in the last 2 years. It may not be the same as being in person, but it still has given us a way to forever be connected while at the same time protecting our compromised immune systems. At the beginning of March 2020, CSCDE made the decision, like every other business in the US, to shutter our doors. And we built a virtual platform overnight utilizing Zoom and Facebook Live to house our support groups, our mind-body classes, and educational workshops. In the first month, we were all under the impression that we would be back to some kind of normalcy soon. And it took a month for our participants to realize that the pandemic was not going to be short term. We weren't going to be back at the end of March or April. And once everyone became somewhat comfortable with using Zoom and Facebook, everyone was grateful, as seen in the comments on the slide, for the services provided. They are not alone, not feel part of a community, and can still connect with their support groups. Next slide, please. So our dramatic increase in numbers. We have a dramatic increase in numbers. We have gone, our cancer patients, caregivers, and families have been happy to stay connected over the past 3 years. In the past 2 years. In 2019, we saw 1,200 people served. In 2020, really beginning in March of 2020 through the end of December, we saw 6,100 people served. And in 2021, as of last year, we saw 13,600 people served, which was a huge, huge increase for us from 2019. We wondered how, in our strategic plan, how we were going to jump from 2019's 1,200 people to 13,000 and increase. And of course, we saw that with the pandemic. Our cancer patients, caregivers, and families have been happy to stay connected. It's been a trying time during the pandemic, and you add a cancer diagnosis and the isolation that can bring, and we were able to offer a connection, a way to stay physically and mentally fit, involved with the outside world and with other people that understand what they have been facing. Also, the virtual platform has allowed us to reach communities within Delaware that we never reached before, and we've reached beyond Delaware into the surrounding areas, into Kennett Square, Chadds Ford, Elkton, and into Southern Jersey. So the role, next slide, please. The role of social media, website, and other tools that have made us successful in the last 2 years. CSCDE was fortunate to have 2 women on staff who began our journey with our social media presence before the pandemic. However, as we began to utilize our virtual platform in March 2020, we quickly came to the realization that our social media and website were going to have to be intentional, interesting, coordinated, and on a schedule. We began with a Friday slider to post what was going to be next week's programming. We added a Monday morning virtual calendar for the upcoming week's Mind, Body, and Education. We added Do You Know posts, which quickly became popular because they informed the public regarding cancer awareness. We connect people through a Saturday newsletter, which always has a nugget of important information, colorful posts, and the coming week's calendar too. And finally, the website, our website, went through an overhaul to include a virtual calendar, a virtual programming page where we utilize JotForm for our participants to be able to sign up, and then we can remind them and send emails once they give us their virtual registration. All of this was built over a matter of months and has been tweaked and refined as time has gone on. We're now in a new phase where we're adding in-person support and beginning to open our doors again. So we're creating a hybrid environment. That means the cancer patients who are not comfortable coming back in person or can't be back in person because of treatment will still be able to access programming through the virtual platform. Next slide, please. So our keystones to success: our increased value of community partnerships, our flexibility of funders, grantors, and foundations, and the Insight Cancer Care Assistance Fund. First, to speak to our community partnerships, we have strengthened our relationships with the hospital systems through our state. Christiana, Bay Health, and BB's Cancer Centers all have played a large role in utilizing our emotional, physical, and financial services that we have to offer. Our relationship with the social workers, nurse navigators, and doctors has been strengthened, and CSCDE has collaborated numerous times with different medical professionals for speaking engagements, workshops, and utilizing for facilitating support groups for us. Our community partnerships with the University of Delaware and the Delaware Art Museum have produced important collaborations and workshops that benefit our cancer community in Delaware. The flexibility of funders, grantors, and foundations has been crucially important and appreciated by all nonprofits in the state of Delaware over the past 2 years. Our particular funders at CSCDE have been flexible in many different instances, from allowing us to keep sponsorship funding when we went from in-person events to virtual events, to making sure we could use funds towards operational support and not limiting or restricting to exact programs. This has allowed CSCDE to build our virtual programming, to add new programming where necessary, and eliminate programming that was overlapping in counties. And finally, one of the most important community partnerships we have is with Insight. CSCDE and Insight created the Insight Cancer Care Assistance Program back in 2018 because we both saw a need arise from the Cancer Moonshot Summit we conducted together. The need for emergency financial assistance has only grown over the past 2 years during the pandemic, and we don't see that changing anytime soon. Again, our hospital partnerships play a large role in making sure we are reaching the population who needs the service the most in Delaware. And the final slide, please. Looking forward, the mission impact of COVID-19 on the future of CSCDE, reevaluate our support and program offerings, reevaluate our delivery model, our hybrid platform, reassess marketing strategies, and adding the financial assistance. The pandemic has played a large role in our new three-year strategic planning beginning in 2022. This gave us an opportunity to reevaluate our support and our program offerings. Look at what's critical for the next 3 years, what we could eliminate, what we can add, reevaluate our delivery, and what we have seen firsthand that the hybrid model is going to be the near future for CSCDE. I told you that the pandemic taught us to reassess how we market our services, utilize social media and virtual programming page, and utilize virtual fundraising more than we have ever done through events, platforms, and appeals. Continue our conversations with funders regarding the flexibility of funding and the appreciation for this mindset. And finally, adding a new component to our mission that for so long have been focused on emotional, physical, and educational support for cancer patients, caregivers, and families. We were one of the first ones in the country for cancer support communities to add the financial component for assistance and to add a component during COVID for prevention. We see it as our job too to remind and educate the people of Delaware not to forget their cancer screenings. During the past 2 years, more than 9.5 million screenings have been missed in the United States. We have the platform, and we will use it to educate and inform a cancer support community. Next slide, please. I thank you for your time, and you on the slide are my contact information, Erica Narducci, our program director. Thank you.
Nicole, thank you so very much. And just thanks to every single one of our panelists. And it's just a real pleasure for me just to be able to thank everyone. We have about 2 minutes to answer any questions that people have. And we do have a couple that are specific about the breast cancer incidence for Dr. Siegel. One is about survival rates of TNBC in Delaware. And then the other is your impression or your research around any hot spots or cold spots in the southern end of the state in Sussex County.
I'm not sure I understand part one of the question, but for part two, I can say that we are working with the state in order to look at this with statewide cancer registry data. We focus mostly in Newcastle because we were working out of our cancer center's registry, but yes, we're definitely interested in looking at this statewide. Yes,
that makes a lot of sense. The other question was, are you aware of the survival rates of TNBC in Delaware?
Oh, yeah, they're comparable to what you would see nationally. So really the fact that we have higher rates contributes to, it doesn't entirely explain the disparity. There are disparities of other subtypes of breast cancer, but yes, we see that the survival is comparable to what you see elsewhere.
Yeah. Just a question for Nicole. What would you say are some of the most challenging things for those in treatment and those who care for them on positive survivorship, and how have those been affected by COVID at a personal level? I know the numbers were really significantly increased.
So you're talking about the caregivers.
Yeah.
Remember,
we have about 30 seconds, Nicole.
So as a caregiver, remember to take care of yourself too. So in our support groups, the caregivers challenge each other to take care of themselves, because if they don't take care of themselves, they can't take care of their loved ones diagnosed with cancer. So that's the short answer.
Great. That's really terrific. And I think that we are now, I have many other questions, and I have asked the speakers if they would do us the favor of answering questions. And as I mentioned with Ms. Calhoun as well, that we will then provide those answers to your questions to make a wrap up kind of the retreat for you, posted after the retreat. So it's a sort of a double opportunity, and I hope that will work for people. As we are now at 10:55 and we're expecting the governor, I think that my job now is just to thank very sincerely and with a great deal of appreciation Ms. Calhoun, Representative Johnson, Dr. Siegel, and Ms. Pickle for helping us really today think about these things in a way that is rich and varied and systemic. And that seems to be a theme that each of you is encouraging us to think about, the system of issues and the system of solutions. So thank you very much for all of your hard work on this and for all of your expert thought. And now I will hand it back to, I think, Katie.
Yes, thank you. Thank you to the panelists. It was just amazing the amount of information you shared. And thank you to Mary for being willing to really wrap everything together and share that information with us as well. I know that people have a lot of really, really good questions. So now, sorry about our break. Hopefully everyone's hanging in there. But I would like to take this time to mention that the Lieutenant Governor who was with us earlier had to dash off to train the next generation of healthcare workers in the state of Delaware, but she was able to sign the proclamation, and you all did get to hear from her earlier. So please now, if you could join me in welcoming my friend, Governor John Carney.
Good morning, everyone. It's great to be with all of you this morning once again for the annual planning retreat of the Delaware Cancer Consortium. I want to thank the Lieutenant Governor in her absence for her continued service on the consortium. She was one of the initial members of the group, including many of you that are on the Zoom, as I understand it. And I want to first thank Katie. I want to thank all the members who are currently serving on the consortium. And I especially want to thank and mention legislators, the 4 legislators who are representing the House and the Senate. Representative Johnson, who you've heard from, Representative Briggs King on the House side, Senator Pickney, and Senator Lopez on the Senate side. I want to thank Katie for your leadership, for agreeing to take on this challenge, filling big shoes of Bill Bowser, who was the original chair and led the consortium for many years. Special thanks to the physician leadership that we have on the consortium, Dr. Grubbs and Dr. Petrelli, Dr. Spellman in particular were original members, as I recall. And frankly, a big reason for the success that the effort has seen over the last 20 years. Hard to believe that it's been 20 years since the inception. I was at the beginning. The other last thing I want to do today, other than make some observations about the work of the commission, is to present a tribute in memory of Governor Ruth Ann Minner to the family at the end, and I'll do that. But I remember well, just shortly after Ruth Ann was elected and sworn in January of 2001, in March of that year, a resolution passed in the General Assembly establishing the Cancer Consortium, the Cancer Council on Incidence and Mortality. And I remember in particular that Ruth Ann asked me to approach Bill Bowser, who's a really good friend of mine, and we knew of his commitment, his passion for addressing cancer in our state. His oldest son was a leukemia survivor. And Bill said, when I asked him on behalf of the governor if he would chair the newly formed council, he said, well, is the governor serious about it? Is the governor willing to put resources behind it? Is the governor willing to make a difference? And I told him, I said, well, you're going to have to call the governor and ask her that. My sense is this: she's very committed by it. She watched her husband die of cancer in a very painful way, and I know it affected her and the work that she did over the subsequent years. A long story short, Bill took over as the chair of that council, and I went to my archives last night to just take a look at their work. And this is the recommendation of the Delaware Advisory Council on Cancer Incidence and Mortality, published in April 2002, which is, I guess, given that we're now in April of 2022, where the 20-year anniversary comes from. And I thought that I'd take a look at what the council was recommending. And they were very focused from the very beginning on following the research and the science with measurable goals. And what the goals that they established over the long term were to decrease cancer incidence rates, to decrease cancer deaths or mortality rates, to make Delaware a model for quality cancer care and early detection, to eliminate the differences in cancer rates between different races, genders, and socioeconomic groups, and lastly, to learn more about who gets cancer and why. Check, 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 check. 20 years of success doing just that. And you know what I'm talking about in terms of the results and decreased cancer incidence and mortality rates being a model for the rest of the country. Specifically, the focus they recommended was to increase screening for and early detection of colorectal cancer with a very focused effort on colorectal cancer. The idea was that it was the cost benefit was strong, and that they had a procedure that a colonoscopy where you could identify precancerous polyps, remove them, protect cancer in the first place, and cure it in the longer run for those that they have gone further than that. Provide the highest quality care for Delawareans with cancer. We've continued to do that. Pay for cancer treatments for the uninsured. I know that has changed with the Affordable Care Act over years, but it's still being done today. Provide reliable, usable cancer information. Really important. Reduce the threat of cancer from the environment, something that we continue to address, and increase our knowledge about cancer, including environmental causes, and importantly, probably most importantly, to reduce tobacco use and exposure. One of the things that Governor Minner, probably the one thing that Governor Minner was most remembered for, was her Indoor Clean Air Act, which, and you think about going into a restaurant or any indoor facility today and think that at one time there's lots of cigarette smoke in those places, and how much better those environments are today, and the impact it has on the health of Delawareans. What an incredible legacy for Governor Minner and for the consortium. In the report, there's also a quote from Bill Bowser. And what he says was that back then, 20 years ago, the recommendations of this council will be a powerful force for change. We know what needs to be done, who should do it, and where we should go from here. Delaware has the opportunity to take action and make positive changes in the lives of all its citizens. In my 30 years of public service now, I've never been involved with an effort or group that has had greater success than the Delaware Cancer Consortium. Staying focused, being driven by the research, really being led by our physician community, bringing all the various interests and stakeholders together, getting the resources necessary to drive the focus on screening, focus on underprivileged communities, addressing the treatment and screening disparities that exist. And so today, we talk about many of those successes: the elimination of the disparity in colorectal screening, the improvement in incidence and mortality rates, the decrease for all populations, and larger decreases in incidence and mortality rates for Delawareans of color. No other effort, in my experience, in Delaware government has been that successful. Why have we seen that success? I have my own views. First of all, it's been research and data-driven, with very specific and measurable goals, with strong leadership. Bill Bowser, Katie Conley, the physicians that have been there the whole 20 years, and providing the necessary resources, again, with broad stakeholder involvement. So I just want to thank everybody that's been involved in this effort, with our Division of Public Health, our Department of Health and Social Services, who support the efforts of the consortium, all the stakeholder groups and nonprofit agencies who put so much of their time and energy into reducing cancer and treating those who have cancer, and providing solace for family members and all of us that are affected by cancer. For many years leading up to Governor Minner's election, previous governors and elected officials and the public at large kind of wringing our hands about what we should do about the high incidence and mortality cancer rates in our state. Not just about knowing that you run into hasn't been affected by cancer in some ways or another. The people in the consortium have made an incredible impact doing things that were measurable and where we've seen real results. And so this year we're saddened to see the death of our beloved Ruth Ann Minner, who was the first female governor in the state of Delaware. One of the things that she will be long remembered for is her effort to address cancer incidence and mortality in our state. Her commitment in forming the original Delaware Advisory Council, which resulted in the recommendation for the consortium that meets today in their annual retreat. That report that I showed you earlier was entitled Turning Commitment into Action. And essentially what we saw over 20 years was the commitment of Governor Minner and folks that she worked with to address cancer in our state. And so it's a great privilege for me as governor today, as an original member, when I was lieutenant governor of the consortium, to present a tribute. I don't know if Lisa is on, if Lisa representing the family could join me here on the screen. I can see something happening there. She's trying to come in. And while she joins us, I will read this memorial for Governor Ruth Ann Minner. Be it hereby known to all that John Carney, Governor of the state of Delaware, and Bethany Hall Long, Lieutenant Governor, and the Delaware Cancer Consortium, calling the people of our great state to honor the memory of Governor Ruth Ann Minner. Governor Carney and Lieutenant Governor Hall Long joined family, friends, and Delawareans across our state in paying tribute to the extraordinary life and service of former Governor Ruth Ann Minner. Governor Minner's life and career were that of a trailblazer, especially when it came to the fight against cancer. At a time when most people were afraid to say the word, Governor Minner brought cancer to the forefront of discussions among members of the medical community, funders in private and public sectors, local service organizations, and at the family dinner table. She integrated her personal passion for the cause and love for all Delawareans to introduce, implement, and expand some of the most aggressive and effective actions in the state. Governor Minner fought relentlessly for Delaware's Clean Indoor Air Act, the most comprehensive indoor smoking legislation in the country. A few years prior, she signed the resolution that created the Delaware Advisory Council on Cancer Incidence and Mortality, the predecessor of today's Delaware Cancer Consortium. Cancer prevention was always a priority for Governor Minner throughout her terms as a state representative and senator, as lieutenant governor, and finally as governor. Her actions and emphasis on working together led to improved incidence or mortality rates that continue today. Equally significant was that Governor Minner enlightened and empowered Delawareans to prevent cancer by adopting healthy lifestyles and improving access to screenings and treatment. Governor Minner was a selfless leader, an ardent fighter, a woman of personal and professional integrity, and a person of action and impact. It is our honor to remember her remarkable life and her many contributions that improved the health and welfare of generations of Delawareans. It is our privilege to carry on her legacy for the health and future of our fine state. Presented on this 11th day of April, 2022, by order of the governor. And Lisa, Ruth Ann Minner made an incredible impact on the state of Delaware as our first woman governor, especially in addressing the scourge of cancer in our state.
Thank you. Governor Carney, I'd like to thank you on behalf of my family, my father, my uncle, who are not here today. And I had to smile as I was reflecting on your question, or Mr. Bowser's question about if she was serious about it. I think you may be best positioned to answer what she might have said if she was serious about something, but clearly she's committed to this, a tenacious personality and a fierce advocate for those that she wanted to defend and wanted to learn more through education and preventative care. And so that legacy lives on with the tremendous work that I've heard about this morning that you all through the consortium continue to address. And I'm grateful for you honoring her today. Thank you.
Thank you, Lisa. When Bill asked that question, I kind of smiled and laughed, knowing Ruth Ann as I do and did. She was as serious about it as a cancer diagnosis, and that's a really serious matter. And she was as serious as that, and came from a personal commitment, as you know, family experience, and she followed through in an incredible way.
Thank you.
Thank you, Lisa. Back to you, Katie.
Thank you, John, and thank you, Lisa, for being with us. Your grandmother was truly a remarkable person. I was privileged to know her, and she really did leave a legacy for the state of Delaware. So thank you, everyone. I thought we were going to have a slideshow. we're going to go ahead with that.
Our cancer journey started in 2002. Then, as now, it's been guided by stories of people whose lives have been touched by cancer. Delawareans who told us how they couldn't afford cancer treatment, or didn't know about cancer screenings, or were diagnosed when cancer was life-threatening. Between 1994 and 1998, cancer was the second leading cause of death in Delaware. Delaware also ranked second in the nation for cancer mortality. Since the Delaware Cancer Consortium inception in 2002, the members have remained committed to reducing the state's cancer burden. Many of the original members continue to serve to this day. Today, we rank 15th in the nation for cancer mortality. Between 2003 and 2007 and 2013 and 2017, Delaware's cancer mortality rate decreased by 7%. The cancer rate was 184.7 per 100,000 people from 2003 to 2007 and decreased to 171 per 100,000 people from 2013 to 2017 and continues to decline today. There is much we have achieved over the years. Now, we have success stories to tell. Our work in cancer has made history. From the passing of the Clean Indoor Air Act in 2002 to our work to reduce colorectal cancer incidence and mortality. Between 2003 to 2007 and 2013 to 2017, incidence rates for colorectal cancer decreased by 26%, and mortality rates have fallen by 21%. Today, nearly 77% of Delawareans aged 50 to 74 report meeting the colorectal cancer recommendations. That's higher than the national median of 74%. More breast cancer cases are being diagnosed in the earliest, most treatable stage. Between 1980 to 1984 and 2013 to 2017, the percent of female breast cancer cases diagnosed at the local stage increased from 42% to 68%. 73% of the women in our state 40 years of age and older reported having a mammogram within the previous 2 years. The national median was 72%. Over the past decade, incidence rates for lung cancer have decreased 17% among all Delawareans. This is particularly noteworthy since between 2003 to 2007 and 2013 and 2017, lung cancer incidence rates decreased 31% among African American men. To help people stop using tobacco, the #1 cause of preventable death in Delaware and the nation, Delaware has offered cessation services free of charge to any resident. There has been a drastic decrease in smoking among adults since our work began in 2001. We started at 25.1%, and now we are at 15.1%, which is a 39.6% decrease. Because we wanted cancer screenings to be available to everyone, regardless of their ability to pay, Screening for Life has served more than 50,000 men and women who are underinsured or uninsured with cancer screening services. Since 2004, we have paid for cancer treatment for those who can't afford it for up to 2 years. We have served more than 2,300 people with life-saving services. Since 2004, cancer care coordinators have been instrumental in helping alleviate the burden of finding care that falls on those without resources or knowledge to seek them for themselves. Partnerships among health systems, federally qualified health centers, nonprofit organizations, and other healthcare practices have played a critical role in how Delaware has reduced its cancer mortality. While we have made great strides in addressing health disparities, we haven't eliminated all disparities yet. African American men continue to die from prostate cancer at twice the rate of Caucasian men. Lung cancer continues to be the leading cause of cancer death. It represents 27% of cancer deaths in the period of 2013 to 2017. Lung cancer has the lowest survival rate of only about 24% compared to other more common cancers. According to the 2020 Behavioral Risk Factor Survey, only 27.9% of smokers completed a lung cancer screening. These disparities in prostate and lung cancer are not unique to Delaware. It's a national burden. We also understand how lifestyle behaviors affect chronic disease. The DCC was tasked by Governor John Carney with developing a roadmap on how to implement healthy lifestyle policies to support physical activity, nutrition, and obesity prevention. The Delaware Cancer Consortium will continue to encourage everyone to get regular preventive health and cancer screenings, as well as to eat right, be physically active, and avoid tobacco and excessive drinking. Our current successes are the result of the work of thousands of hours of meetings, data analysis, partnerships, and consultations of the Delaware Cancer Consortium volunteers. Let's continue to be innovative pioneers to address our state's cancer needs. We look forward to what's ahead. It may be a new era, but we're staying true to our legacy and making the connection about the importance of healthy lifestyles and staying cancer-free. Here's to the next 20 years and all that we can accomplish together.
Thank you. That was just a fabulous slideshow. It really was well done. I want to thank Governor Carney again and Lisa Peel for being with us. It was a really moving tribute. And I mean, as you heard from what Governor Carney said, he and the Lieutenant Governor have been dedicated to the consortium from the very, very beginning. And it's through their leadership and their commitment personally and financially with state funds that has really let us be as successful as we have been. But also, in addition to all of the people that are still with the consortium 20 years later, the doctors that the governor mentioned, it's really the people at DPH and the hard work that they put in every single day. And it is my pleasure to introduce Helen Arthur, who is going to talk to us about the future of the Delaware Cancer Consortium. So let me just tell you, Helen is the section chief of the Health Promotion and Disease Prevention for the Delaware Division of Public Health. And she's going to walk us through the Delaware Cancer Consortium's 5-year action plan.
Thank you so much, Katie. I want to thank you so much for leading the Delaware Cancer Consortium and giving me the opportunity to present the 5th 5-year plan of the Delaware Cancer Consortium. The title says a lot about the focus of our new efforts, taking our past successes into consideration in all we do, and making healthy living messages and initiatives the center of our actions. I think the slideshow is up, so I'm going to ask for the next slide. I'm not sure if I can see it. Are the slides moving? Please confirm. Thank you. Thank you. Okay, so let's look at where we are today and what we know from the data. And I'll be brief because we've heard this already. The numbers are trending down. Cancer incidence and mortality rates are in a steady decline. We are now 15th in the nation for mortality and second for incidence. Next slide. So when comparing 1980 to 1984 with 2013 through 2017, cases of breast cancer, cases of breast, prostate, and colorectal cases were being diagnosed mostly at the local stage. Lung cancer continued to be diagnosed mostly at the distant stage. Lung cancer is still the leading cause of preventable death in both Delaware and in the United States. And although lung cancer mortality has trended downward in Delaware since 2003 to 2007, males continue to be more impacted than females. And we heard that a little earlier today. Not sure what's happening to my slide, so give me one moment. Although prostate mortality has decreased since 2003 to 2007, the disparity gap among Caucasians and African Americans have existed over time. We also know that cultural and health disparities affect cancer rates. Where people live and how they grow up influences not only attitudes, but also access to care. The new five-year plan includes cultural inclusivity and health disparity initiatives to address those inequities, and education, appropriate language, and better ways to assess quality care are addressed across the board. So focusing on healthy lifestyles is a key driver, and we've heard that throughout the day, because so much of what drives chronic diseases like cancer involves healthy eating and active living. Promoting healthy lifestyles will be a center message moving forward in all the work that we do. So, what is the plan? The action plan includes specific goals and objectives for each committee to guide our work for the next 5 years. The Delaware Cancer Consortium Advisory Council has 5 goals. And this work will include overseeing the work of the consortium, including committee members from target populations, guide the plan development, including health disparities, and will serve as a leader and for resources. The DCC will also reimburse the cost of treatment to those who use Delaware Cancer Treatment Program, support survivors to improve survival rates, particularly among populations where cancer survival has decreased. The Early Detection and Prevention Committee has 6 goals, and the objectives for the Early Detection and Prevention Committee include things like identifying populations who are being diagnosed with cancer at late stages and develop education and outreach initiatives, promoting screenings through patient navigator education, new relationships with providers, FQHCs, and Medicaid, achieving a 50% increase in the number of men age 50 who discussed prostate screenings with their providers, promoting breast cancer among women rarely and never screened, increasing the screening rate for lung cancer, providing HPV vaccines to girls, boys, young women, and young men ages 9 to 26, educating parents, physicians, and consumers about them. In addition, the committee will work to analyze state data to cancer screenings and become a repository for chronic disease data, as well as provide updates to providers. And they'll engage patients and promote health literacy through patient navigation services and support staff. The Cancer Risk Reduction Committee has about 5 goals, and their objectives are to meet things like encouraging healthy lifestyles, developing campaigns that support healthy eating and active living, supporting healthy lifestyle goals through partnerships and state policy recommendations, promoting the Lieutenant Governor Challenge, using culturally inclusive and equitable language and messages to educate the public about ways to lower cancer risks, supporting national tobacco initiatives, reducing exposure to secondhand smoke outdoors, continuing to prevent initiation of tobacco use and tobacco products among youth. There's just a host of things. They also will work to increase the number of people who stop using tobacco and tobacco products, continuing to provide counseling, cessation, implementing statewide initiatives to address activity, nutrition, and obesity prevention. And we heard from the Lieutenant Governor earlier today relative to mentioning the work of the Healthy Lifestyle Subcommittee's 14 recommendations. The Cancer Risk Reduction Committee has played a key role in that space. So the Delaware Cancer Registry Committee has 5 goals, and they will continue to act as a linchpin to all members of the consortium, offering its data services to improve our understanding of at-risk populations and trends. The DCR's next 5-year plan objectives to reach their goals include things like continuing to participate in the CDC-led data modernization project, which assists reporting sites in moving to a cloud-based data collection system to help eliminate the 3-year data lag experienced by national cancer registries. Participating in the National Cancer Institute, North American Association of Cancer Registries zone design project to create sub-county zones, which will yield more meaningful information on possible cancer clusters or areas of concern. Continuing to follow the national program of cancer registry standards for data completeness and quality control checks, and enhancing data visualizations by creating a web-based tool that will allow the public to interact with cancer data. So they have quite a few objectives on their plate. So together we can contribute and continue to make a difference in helping Delawareans reduce the cancer risks and reduce their cancer risks. The work is so important to the Division of Public Health, and we are honored to serve as support staff for the Delaware Cancer Consortium. The new Delaware Cancer Federal Grant Programming and this document serves as our state cancer plan. Thank you so much for your continued support and collaboration as we work to keep all Delawareans cancer-free. We have a lot of work still ahead of us, but I thank you all for your dedication and your partnership with us through this process. Katie, I'm going to turn it back to you.
Thank you, Helen. The next 5-year period is certainly full of promise, and I have no doubt that here with us today, we have the people to get the job done. I want to give a special shout out to Helen, who really was the heart and soul of this retreat. She kept us moving forward. Even though we're virtual, she made sure we got it done. It has been a fabulous retreat, and we have to thank Helen for all of her hard work. I also want to share a heartfelt thank you to all the members of the Delaware Cancer Consortium, to the Early Detection and Prevention Committee, to the Cancer Risk Reduction Committee, to the Cancer Registry Advisory Committee members. We have to recognize each one of you as well. The work is not possible with each one of you, and I think it's so important to recognize you all and say thank you, especially because so many of you have been doing this for 20 years. And luckily, you can see the fruits of your hard work, but we still have a lot of hard work in front of us. Before we close, I want to remind everyone that all presentations from today's retreat will be made available on the Healthy Delaware website. We'll have them posted before the end of the week, so please feel free to watch and share them. And thanks to Mary Kane, she is going to work on getting some more of our questions answered and adding them to the retreat presentation. So we really appreciate that, Mary. That'll be nice for everyone to have. And with that, we conclude the 2022 Delaware Cancer Consortium Retreat. While our event may be coming to a close, our work empowering more people, changing unhealthy behaviors, and saving more lives is just beginning. Before everyone logs off and goes about the rest of their day, I once again want to extend thanks to all of our presenters, speakers, and panelists. They were truly amazing, and I know I learned a lot. I also thank all the incredible people behind the scenes. As I mentioned, DPH has just been amazing. And also I want to thank ABC Creative for putting the retreat together for us today. They've been working for at least 6 months to get this organized, and it really was amazing. So lastly, I want to thank everyone who listened and logged in and learned with us today. Thank you for your thoughtful questions and engagement, and thank you for taking the tools and knowledge you now have out into your communities to prioritize healthy living. Thanks, everyone. Have a great day.